like to involve the next panel. Dr. Rishi Nair, Dr. Raj Patel, Dr. Rakesh Sharma, Dr. Rajesh Taneja, Dr. Himanshu Shah, and Dr. Ashwin Gabani. To start the next section, we have Dr. Anant Krishnan Shivaraman, and he will be talking about freehand transperineal biopsy.
Hello, good morning. So, I think before we go on to learn transperineal biopsies, Dr. Makarand is telling us not to do biopsies, right? So next is Dr. Manohar is here. He's just bought a machine for 1.5 crores that does fusion biopsies, and then you tell him not to do biopsies, what will happen? Huh? Anyway, just in jest, let's go on to the topic per se. One of the reasons they mentioned about not doing biopsies is complications because of biopsies, and this entity, transperineal biopsies, literally has minimal complications in terms of sepsis. So why should we shift? I think the main reason is sepsis. Sometimes all of us in our practice have had one patient that really has had major trouble after transrectal biopsies. They go to the ICU, urosepsis, significant sepsis, and also a very small percentage of mortality involved there. Significant morbidity, definitely a small percentage in mortality. I won't go on to the details. Now this is EAU 2024. The first choice has come out to be transperineal biopsy. If you have the means to do a transperineal biopsy, you should go ahead and do it. If not, then go to a transrectal biopsy. That's where we are at present. And I'm not talking about, where you need a stepper, you need a general anesthetic, you need to put 15 to 20 holes in the perineum and do transperineal biopsy. This is done as an outpatient, right? Patients come in and go home within 3 hours. So it's freehand transperineal biopsy. All you need is a stabilizer. It's a small stabilizer. I'll show you what we mean by it. And all we need is a biplane probe. Now, these biplane probes don't come only in the machines that cost 1 crore or 1.5 crores or something like that. It is available in all ultrasound machines that start from 20 lakhs onwards. So it's not something that you have to spend too much to achieve, right? So like I told you, you need a biplane probe. It's available in most places, most ultrasound machines, not just in the big companies. Then you need a stabilizer and most importantly, a mindset change. Right? So I'll go on to what we mean by the stabilizer. Here, when you have a BK machine, they come with their own set of stabilizers. Then you don't even need stabilizers. If you are good enough, after a period of time, you just need a coaxial technique, a large needle, and through which you can take biopsies. All you need to do is make sure the needle is in front of the array that you're using. So this is used in Cambridge. It's called CamProbe. And this is what I use. It's called a precision point device, and it's a stabilizer that we use that allows us to take biopsies with a transperineal probe. So this is a locally made stabilizer. We are in Ahmedabad. This gentleman who makes this stabilizer is from Gujarat. Sri Surgicals makes this, and this can be used for your transperineal biopsies as well. You definitely need a biplane probe. There's no getting away from it. So this is a 3D printed version of the precision point, and this is also available. It's going to come out in the market soon. And it's available in all ultrasound machines. This is what I was pointing to you about. It's available in SOT, it's available in GE, it's available in Mindray. All of these machines have the biplane probe. So you don't need a very expensive machine to shift over to transperineal biopsies, right? So all machines, this is what I was trying to tell you. And then let's go on to quickly the way in which we do transperineal biopsies. The first step is to check the alignment. All of these biopsies are dependent on our ability to analyze cognitively where the lesion is, and then exactly point out to where see the needle go directly into the prostate. All steps of this, seeing the needle through the entire zone of the prostate should be done before, right? We need to make sure the alignment is good before we start the biopsies. That's important. So every step of the needle should be seen, the entire prostate should be seen. So first step is local infiltration. You get the probe inside, see where the prostate is, and then you can start infiltrating local. I won't go into details of this because it's very simple, straightforward. In the perineum, all you need to do is make sure you avoid the bulbar urethra at the sides, right, in the middle. So go to the sides, and then you can before you start, you can infiltrate both sides, and when you go to the other side, it doesn't pain at all. So the important point here is there's only one puncture in the perineum on either side. Left side one puncture, right side one puncture, and then you can tilt the probe up or down and then take biopsies in different zones of the prostate. So this is local infiltration. How far do we infiltrate? One, on the skin level, the local is infiltrated. The next is periprostatic, especially in the anterior aspect of the prostate. This is where you're going to go in. Under the levator, it's called the space of Alloway. This is where you will infiltrate local. So fundamental differences between transperineal and transrectal is, transrectal you have apex, midgland and base. Here you have the anterior zone, mid zone and the posterior zone of the prostate. So this is where you're differentiating. You don't specifically have these apex, midgland and base. So when you look at it, you have to take biopsies at these three levels. Suppose the prostate is very large, you will also take basal biopsies. The advantage here is the cancer detection rate is higher, and the reason is most of the biopsies go through the peripheral zone. Sometimes when you're doing transrectal, some of it is in the peripheral zone, some of it is in the transitional zone. Here, most of it has to go through the peripheral zone. It's like your prostate's holding an umbrella out in front, and then you have to poke the umbrella and then go into the prostate, and that's the peripheral zone for you, right? So before we do a biopsies, I would ask all of you to get a proper radiologist to mark where you need to take the biopsies, and this is important because unless you know where to take the biopsies, your biopsies are going to fail. So this is key. I don't do any prostate biopsies nowadays without a proper MRI. So I won't go into details of what you do with Pirate score, but this is important. Do we need software fusion? Do we need hardware fusion? As it stands, current data, 2024 EAU guidelines, there's not a big difference between these fusions and cognitive biopsies, right? So this is our template for transperineal biopsies, and I'm going to show you how the biopsies happen with in transperineal zone. So there is a small screen shows you where the needle goes in. You need to see the entire tract of the needle. That's important. And then here we're taking right anterior medial aspect, and this is anterior, mid-zone and posterior. That's important to understand. Then you can take lateral and parasagittal and posterior, but most of the biopsies come in the lateral aspects. So here I'm targeting the right base. Now the sagittal part tells us whether we are in the posterior zone or in the anterior zone or in the middle. Now look at how I'm pushing my hand up and taking the posterior zone. If I needed to take the anterior zone, the hand comes down and I'll target the anterior zone, right? And the transverse array of the ultrasound tells us whether we're in the left or right, or how far lateral we are and how far medial we are. So both have to be used. It has to be a biplane probe. You need to see both images on screen when you're taking the biopsies, right? So we're done, last minute. Again, this is left anterior medial, and here you see again my probe is lifted up, pushed down, so I'm taking the anterior aspect, and the needle has to be seen throughout. Now, do these patients need anesthesia? No, it's only local anesthesia. Initially when I started, I used to give them some sedation, but now it's only local anesthesia, right? So here it's right posterior lateral. Again, look at what we're doing, lifting the probe up a bit, turning it to the right side and taking a biopsy here, right? You can either rotate the probe to reach the right side or push on the contralateral side, your probe to the contralateral side, so you reach the side that you want. So we presented this a few years ago. Our data on transperineal, the first 50 cases. Now we've crossed more than 300 cases of transperineal biopsies. And I haven't looked back. I've never had the need to do a transrectal biopsy in the last 4 or 5 years. So I think as a nation, we should shift over to transperineal biopsies. Thank you for the opportunity.
Thank you, Dr. Anand. Next, we have MRI fusion transperineal biopsy, Dr. T. Manohar.
Good afternoon. Thanks for the opportunity, Uro-Oncology team. So I just brush up on the technology of the MRI fusion. It's a stepper with a stabilized biopsy, which I'm going to talk about in the days of precision oncology and precision biopsy. So that's the way forward. So regarding the technology, as far as the tracker, I think Dr. Anant Krishnan has showed the cognitive fusion with the freehand technique. It also has got a EM tracking. And when you go for a stabilized, you see that it is having the stepper device, and this has got a different probe itself. So it's called a predictive fusion, where you're going to track the biopsies in case of transperineal. So basically, it is the MR of TP stabilized is, you know that I think he has mentioned already that you require the template is different here. I mean, I'm not going to the details into that, but then the targeted biopsies and template biopsies are different as compared to the transrectal. And I think nowadays, I think as the experience moving on, I think now we are moving towards only target-only biopsies, as even if it is 2 millimeter, 3 millimeter, that is the idea of doing this fusion and stabilized biopsies. So one needs to have a proper technology, how to do it. So procedure and technology of MRF is to have the PIRAT scoring 2 vision, wherein you have a T2 images, diffusion weighted images, and dynamic contrast. You can see that this is the T2 weighted anterior prostate, and this is the diffusion weighted sequence where it is diffused with that, and there is a restriction of the restricted diffusion here, and then this is the dynamic contrast enhancement, which shows that this is the 3 important issues you have to identify. You require a good radiologist. Again, you can see that, and this is a restricted diffusion, and then you see the contrast enhancement, and this is the colon. So you may have that, but these 3 things are important. Again, this is just to make sure that hypococuria, contrast enhancement, diffusion, DC, and this is diffusion weighted images. So these are important to identify while doing an MRI. You require a good radiologist, and I think we have been trained the radiologist, and I think it entirely depends upon the radiologist who is good at. And this, what is requirement is the MIM software. This is the very, very important software, and it is the costliest of the, I mean, you said about 1.5 crores of machine, but this software itself costs around 1 crore. So this, what we are going to do, you put MRI, you do an MRI, you take the T2 weighted images, perfusion defect, and diffusion weighted contrast. You see that contouring, the whole prostate has been contoured. You put it into your software, you put it in a computer, and then you take the contouring of the prostate. This, you can do it from the serially, from base to the apex, or apex to the base. You can see that this is the real contouring which you are doing, and you can adjust the contouring. Because the red figure is showing that you can just erase it. You know, if you're going out of the prostate, you can just have to erase it and make it approximately to that area. So this is what on live in the computer we are software. We put the software in your computer on your desktop, and then keep on doing that serially. Each images are representative images. This is the hypococuria. This is the lesion. Now what you did first was the contouring of the whole prostate. Now we are contouring the lesion. So it can do, if you have more than one lesion, you can choose the different color. You can use a blue or red or white. So depending upon the completely, you can each cross section you have taken that. You can see that it's an anterior lesion. This basically is an anterior lesion. And then you move forward and see. And this is the virtual probe. This is very important part of it. This is a virtual probe. The transrectal probe has put in the transrectal area, and we are adjusting. So that what is the dimension of the probe, how to place the probe. So it depends upon, in the MRI itself, we decide that. So the probe itself is virtual image of this probe. Only this machine has got this, and this increases the accuracy. This is a virtual probe in the transrectal probe. And then this software has been transferred now. You put the name of the patient. This has been done, virtual probe has been set, you contour the lesion, and then transfer the whole image into the ultrasound. So whichever the name is there, and now the whole thing has gone into the ultrasound now. So this is the first step. Coming to the on-site table, this is the procedure, the lithotomy position, transperineal route. I think Dr. Anant has already mentioned that. And important is the stepper device. This is a huge stepper device. This is one of the important aspects if you're doing the fusion. And this probe, what the stepper does it, because this looks very big here. This probe has got, you can see that this probe has 6 movements, front and back movement, rotation movement, z-axis, and then x-axis movement, y-axis movement, up and down. So basically you have 6 movements going around with that, because to adjust the prostate, exactly getting to that, this requires. Anesthesia is, of course, earlier, when we started, I started doing GA, but now we are doing with the pudendal block, local anesthesia. In fact, you can see the probe going there, here. You just have to put accurately, you can go to the neurovascular bundle, you inject deposit injection, so you can use a prostatic block also, you can do a pudendal block now. Now we are mostly into the pudendal block and prostatic block. Of course, because nowadays we are very confident of doing the targeted biopsy, because we exactly know what are the periods 4, periods 3, more than 1.5 centimeters. Just give it to the local area, to that particular area, where the tracker is there, where it is going there. Just give it to that area, local anesthesia, take the biopsy, 2, 3. If it is more than 1 centimeter, take 3, 4 biopsies. If it is less than 1 centimeter, take 2 biopsies, just like that. To particular area of the lesion, you can inject the local and then take the stabilized biopsies. Wherever the lesions, if you have 3 lesions, give it at that place area. And this is the whole procedure on the bedside. This is the stabilizer. So the patient is put in a lithotomy position. And this stabilizer has been fixed. As I mentioned, with the stabilizer, you can have the 6 degrees of movement. I just sort of forward this so that we are fixing that. Now, once you adjust all the positions, because you start moving that X movement, Y movement, Z movement, everything, so that you place the probe. This is the probe which you are placing it. They have a different way of putting this condom, or they have given a disposable ones, but I think we found it is. So fix this probe into the area, into this stepper device. And then this is syncing. So the stepper device has been fixed to the computer. This is very important, because whatever the moments you do it, it is transmitted into the ultrasound. So it has been synced now. The stepper device, the sync into the computer, which I show that. So now with the same thing, little jelly, and then the probe goes into the transperineal. So the needle goes to the transperineal, but the ultrasound probe. So you can see the images now. Once you start imaging, now you start transferring the fused images of the MRI. MRI images has been fused now. We are fusing that because identify what is the highest dimension of the prostate you contoured, and then start fusing the ultrasound. Right now we are fusing the images. So once you fuse that images of the real-time images of the ultrasound, now these are the images you get it, different images of the ultrasound, and you can see the lesions also, wherever the lesions, 2 lesions, 3 lesions, whatever you have marked it. And you can see that this is the lesion which now contour has been almost, it's somewhat in a predictive lesion it is. Fast forward this, and you can see that lesion is matching there. So whatever we have fused it, just what matching, and then you take both the longitudinal and cut sections, and the images has to be imprinted onto that area, so that the whole fusion is happening now in the cross section. And now exactly now once you set this is very important part of the whole procedure. If you spend time on this, then the precision of doing even 2 millimeter is accurate. Actually, it is a steep learning curve while doing this. Now, I'm moving the rotating with the stabilizer, with the rotating, you can rotate and the needle can go exactly where you want to intend to, because there's a number is there. This is a stepper device. I'll show you that in a minute. Okay. I'll just forward this. The grid. So once you put the grid, you exactly know where exactly you want to go. Pass. See that? You can see that you rotated the needle there. You rotated the red track there. You want to take a biopsy from here. And then the needle goes. Oh, you need not have to movement. There's no jugular movements here. Straight away, one shot, it goes and comes out, pinpoint. If you do a template, of course, it's a multiple puncture. If you do a targeted biopsy, it's only about a 2 to 3. It's going to show that another lesion. So it's tracked there. You can see the needle exactly. See that? You can track the needle. Come to the capsule. The lesion is red with the lesion. Tracking the lesion. So you're exactly taking the exact point where the malignancy is obviously present from the PIRATS 3 or PIRATS 2 lesion. This is the same lesion which you have taken now. Just a comparison. So this is how the biopsy has been taken. And I think, so this is the whole needle which is going there. So you can have this, wherever the needle is, the second lesion which has been taken, the needle is going exactly. So you go there one from here and then, see that the needle goes, this is the third lesion. So you just go and exactly take the lesion, which is almost actually posteriorly present at the base. So go to that area and then take the biopsy. So this is how the biopsy report comes out. And of course, this is the guideline. I mean, we have made it about more than 3. I think nowadays our people are very good about picking up the 3 and PIRATS 3 and PIRATS 4 lesion. If anything more than PIRATS 3, I think we are going for a targeted biopsy because our radiologist is excellent in giving that lesion. So our matching is now less than 1 centimeter lesion. We are going for, if it is more than PIRATS 3, we are going to do only target biopsies. So we have now started doing with the pyramidal block. The timing is little more. Nowadays we are reducing it. And local anesthesia can be do it under local mapping, pyramidal block, and of course infection rate is nil. Targeted biopsy. We had a retention initially when you were doing template biopsies. Now it is reduced. It's 2 to 9%. And perineal hematoma, it was earlier more. Now it is less because we are going to targeted biopsies. I think I'll just want to do this slide. So because of the targeted, because of this fusion, because of the stabilized, our target only biopsies, the yield is increasing. Only targeted biopsies, especially in for 1.5 centimeters, when it is PIRATS 4, high suspicion, we just do a targeted biopsy and the yield is excellent. Thank you.
Thank you, Dr. Manohar. Next, we have a talk on transgluteal PET-guided biopsy by Dr. Ravi Mohan.
Thank you. So I'm the last one to have this kind of talk, which is on transgluteal. So it's a new kid on the block. So we did not want to create a lot of hype about it. But yes, one good thing is that PGI Chandigarh had taken lead in doing such biopsies in the country, and I just wanted, we had some publications also. So just wanted to take you through that. So nothing to disclose. I think we can skip this for want of time. Why important prostate biopsy? Because it's an organ, if you want to remove it, it creates a lot of complication, and that's why we have so many techniques. So we need to be accurate before we actually want to do anything about it. So these are the kind of complications which we expect. And we all know that one good thing which India had as compared to the rest of the world was we had a availability of PET scan. And all of us started doing PET scan left, right, and center just for the cost. And that's where this kind of idea came up. Okay, can we do a biopsy and make it more accurate? We had, in fact, the patient who had undergone APR, and we had no access to do any biopsy. And that time, perineal biopsy was not something which we were tuned to. So this is how the genesis of this. So there's a small video. There's a voiceover with it. And this is our nuclear medicine MD student.
We have.
Let me know if it is.
A 68-year-old male patient who complained of lower urinary tract. In a multiparametric MRI, the patient had a PIRATS 4 lesion involving the left side of the prostate gland in the peripheral zone. So patient underwent transrectal ultrasound guided biopsy, which came out to be as benign prostatic parenchyma. So patient was referred to us for PSMA PET guided biopsy as well as staging. So this is the maximum intensity projection image of the patient. We can see focal tracer uptake in the prostatic region on the left side. So these are the axial sections of fused PET CT. We can see tracer avid lesion on the left side of the prostate gland. This is advanced robotic arm system, and this is the console of the robotic arm system. This system is Maxio by Perforant Healthcare India Limited. This is our control panel for the robotic arm system. This is our dedicated PET CT machine. We have positioned the patient in prone position to take a regional scan of the prostate for planning for biopsy. Now we have loaded the regional images of this patient on this console, and we are scrolling the images to localize the lesion in the prostate gland. So this is our lesion in the prostate gland. Now we will decide the entry point on the gluteal skin surface and our trajectory to the lesion in the prostate gland. So this system will give us the entry point and our trajectory to the target lesion. Now we will decide the length of the needle according to the depth of the lesion. Now we will give the command to move the robotic arm to the planned coordinates. These are our planned coordinates. Now robotic arm will position according to these coordinates. So these are the planned coordinates and the final trajectory to reach our target lesion from the skin surface through the istiorectal fossa till the lesion in the prostate gland. So we can see the robotic arm is moving. We had already given the command to the robotic arm to position according to the planned coordinates. Now the robotic arm is placed according to the planned coordinates. Now we are cleaning the entry site under full surgical asepsis. The crossing point on the laser points towards our entry point on the skin surface. This is the end effector of our robotic arm, and we have bush. So we will place this bush. So we have placed the bush in the end effector of the robotic arm system. This bush will help us guide the trajectory to our target lesion. Now we are giving cutaneous anesthesia using 1% lignocaine. We are giving a small cutaneous nick using a 11 gauge blade. So we are inserting the biopsy needle through the end effector of the robotic arm. We will insert the needle according to the planned coordinates and the depth decided according to the robotic arm system. We have placed the needle to the planned depth of the target lesion. Now we have unclamped the end effector arm from the bush and needle assembly. Now we will give command to the robotic system to pull back the robotic arm. Now we will do a regional PET CT scan of this patient to see the final position of the needle. We have done regional PET CT of this patient, regional scan of the pelvis. So we can see the needle, and this is the final position of the needle. This is our barred mission biopsy gun. So this is the 2 centimeter cutting edge of the needle with the cradle. Now we are placing the biopsy needle to the target lesion, and we can rotate the cradle. Now we have taken sample from one direction. This side of the needle signifies the cutting edge of the needle on the lateral side. So previously we had taken sample from the medial aspect. Now we are taking the sample from the lateral aspect. So like this, we can take the sample in 8 directions by rotating the needle inside the cradle with only a single puncture to the prostate gland. We can see the tissue sample inside the cradle of the needle.
Yeah, so that was it. I think one of the major problems was if the patient moves in between while you actually planned the trajectory and patient moves. So that's to circumvent that they would do a PET scan again to ensure that the line is maintained. If and it has moved, you have to redo again. So it's still a learning curve, not that we've been perfect. And in fact, there is a difference between if 2 people do it, one of them you would always get a positive result and others you may not. So it's still a learning curve, but it's something which is being done. And the initial experience was published a couple of years back, safety and diagnostic yield, and what we concluded that transgluteal PSMA PET guided biopsy was safe and had a high diagnostic yield, and this was the patients where MRI was found to have a lesion and the biopsy was negative. One of the reasons was we did not have a MR fusion biopsy, and most of the time it is the residents who would do it. And if they are not being very careful, you might actually target a normal benign prostate tissue and end up with it. So I think these are the standard differences where gallium PSMA offers a functional guidance. It's a transgluteal approach, so they don't actually go in to get a urine culture and things like that, where they just give one single shot antibiotic to cover the skin flora. And number of course, you can take multiple course on the targeted lesion, as she mentioned. And the yield was nearly 100%, but it is specifically done by one consultant. As of now, it is the others have not yet picked up. And this is another study which was published from our group, where we compared the accuracy of combined MP-MRI and PSMA PET, and they showed that when the SUV max was more than 8.25, all those lesions which were targeted, and MRI showed up a more than pyrite 4 lesion, all of them almost were positive on a biopsy, could be detected. So I think we already discussed that probably where we are moving in future is Trexit, that can we exit the biopsy at all. So after this, and now I open the house maybe for discussion. Thank you.
So in a PSMA guided biopsy, we are taking only the targeted biopsies. The systematic biopsies are entirely done away with. So how do you reconcile with the fact that maybe probably you are missing on about 10% of significant cancers?
So that study, last study where we did MRI with the PSMA PET combined, that study we had systematic biopsies as well as PSMA PET guided biopsies. In that, they found that when the SU max of a lesion was more than 8.5, there might be lesions which are less than that. Those lesions did not detect any kind of tumor. When it was more than 8.5 and MRI showed a pyrite 4 lesion and above, almost 100% of them were clinically significant. So I think with precision medicine, what we are trying to, although we are not proved yet that we can get away with systematic biopsies as of now, but probably in future, once we have these two things combined, we don't have to do a systematic biopsy. That's what I believe.
So the entire biopsies are now basically the PSMA dependent. Even the pre-biopsy MP-MRI is done away with at your center?
No. So as of now, we are doing pre-biopsy MP-MRI, one to understand the anatomical aspects also, if the patient is a candidate for any surgery or something, even the radiation oncologist.
But that would be post-biopsy.
We do it pre-biopsy. Even the guidelines recommend it pre-biopsy in a localized cancer, right? Even the guidelines say if the MRI has to be done, do it pre-biopsy.
Sir, Keval here. One question, sir. After PSMA, what is the duration when you do the biopsy? Like how much, with how many hours, number one. Secondly, what would be the false positive rate? Because many times, you get high PSMA uptake in prostatitis as well. So many cases. So how would that hamper your findings?
Right. So First question, when do you do it? So typically if you feel that it's a localized disease based on an elevated PSA which is less than 10 or a DRE showing a lesion, a nodule, we would recommend PSMA PET and guided biopsy if you see the lesion. So that ends it's done on the same day. So patient doesn't have to walk in again and again. To answer the second question, we had only one patient in that published study where it came as chronic prostatitis, the biopsy, and the SU max was around 7. So even a 7 was either higher side, it was 7. So I think when we combined MRI with the PSMA and had a cutoff SUV, we probably negated the negative or false positive results.
So how do you select your patient, which patient would actually go for a PSMA directed biopsy?
So as of now, since there are multiple studies going on, almost all patients would go for a PSMA PET and guided biopsy for practitioners who are the part of that study. There are other consultants who may not be a part of study. They would decide MRI versus PSMA. So as I said, it's still process and evolution.
Sir.
So, may I?
Yeah, please.
Sir.
So, the entire focus seems to be reduce infections which we had transrectal. So, we went transperineal. In transperineal, we had a lot of hardware, software, cost. So, we went freehand as we have been shown, and we got good results out of that. You take it a step further, you move back. You had a different portal of exit, but it also required significant hardware.
Significant,
Now,
yes.
Yeah, you had a robotic arm, you had to have a laser guide, you had to have software merging.
That's a part of the PET. If you're investing in PET, it's a very minuscule cost to have this robotic arm.
No, I'm not saying that. I'm just saying that this is not regular. PSMA PET we all have, but I don't have this robot in my PSMA center. You have to acquire it probably.
Yes.
There's a cost to it.
Yes.
Now, the whole fact remains that if you have to put it into general use, you work in an institute where you have it. Others, what are they going to look? They're going to look at simplicity, accuracy, and safety. And I think all this has been demonstrated even in the transperineal freehand. So, what we need to actually figure out is which is the most economic and safe way to get an accurate diagnosis. If all that scores well on a transperineal freehand, probably that is the way we will all go.
Yeah, I agree that. I agree there. Perfectly agree.
So,
What is the procedure time, the average procedure time you spend?
About 10 to 15 minutes.
Okay, and sir,
Because you have to go in and back and forth, so about 10 to 15 minutes.
we have seen 3 techniques. One is only means standard transperineal with targeted biopsies. Then we had only targeted biopsy, and you have a transluteal. Where is the maximum chance of the urinary retentions we see?
So I don't know. I think transperineal, Dr. Anant and Dr. Manohar can answer that part. How much is what is the risk of?
Initial, when you're doing because transperineal, you need to get used to the transperineal. So you tend to do it because even Dr. Anant also must have been trained. While doing transperineal, you touching the actually peripheral zone or the apex, you tend to injure the urethra. So basically the MRI, the experience, I mean it is experience, there's a learning curve is there. That's the reason when we are doing the GA, under GA, and we are doing template biopsies. That is the time retention was high. I mentioned that 2 to 10%. 10% because we are not very sure about the target. MRI, the radiologist was not very sure. They say that, okay, maybe 3, maybe 2, things like that. So now we have a good radiologist. They are focusing, okay, this is the lesion, you go and do it. So now it has come down to less than 2%. Transperineal, definitely, the retention rate is more. In fact, in literature also it says about 10%. But if you do only target only biopsy, just last 15 cases, we don't have any retention at all.
So does primarily putting a catheter before starting the biopsy helps you in a
No,
better
no,
way?
we are not going there at all. We are not going, it's just only the periurethral tissue which is called spasm. Even give a general anesthesia, if you do any procedure, spinal anesthesia, you will have retention. It's just a spasm, and then sometimes, of course, you can hit the urethra also. So that's the reason why we just lift up you saw the position, we lift up the scrotum so that, you just patch up the urethra a little bit above. But sometimes in freehand, sometimes you can hit it. We also tried with the freehand, the needle going here and there, you may hit it. You may hit the urethra, and there's first few cases we had hematuria also.
in terms of the size, okay.
It's quite possible. We can hit the urethra if we're not careful. But it's also very easy to take biopsies just above and below the urethra. Suppose there's a lesion just above the urethra in the midline. you can target it from the lateral side and then go get it. Those cases you can put a K90 when you're doing it, so you know exactly where the urethra is and then take it. But nowadays we don't see a lot of retention at all, to be honest. If somebody is impending retention already and then you do a biopsy on him, then he's going to get into trouble.
Somebody who is initially starting the program, sir, do you recommend to keep a catheter and do the biopsy not in a free hand?
Not needed at all.
So in terms of the accuracy of lesion targeting, I think the stabilized version of the perineal biopsy would give you the best results. Even the angulation of the probe can be adjusted and matched. But for the PSMA directed biopsy, what size of the lesion, minimum size of the lesion that you would require that you would be able to target it precisely? On a PSMA, because it is a diffuse image that you see. Yeah.
So I think we have not looked specifically into that, but one study which was published where we looked in pyrite 4 lesions, so about a centimeter lesion should be okay, but we have not specifically looked, is there a cutoff lesion where we can say, okay, below which we will not be able to target it. That has not been looked into.
So one of the techniques you could do when you have a small lesion is do a focal saturation around that area. So when you do that, you probably target that lesion as well. So there's no specific cutoff. I think less than 5 millimeters, you wouldn't go in and break your head about it. But if it's an entity that you want to target, focal saturation, or take 5 cores all around the lesion and then you will hit it.
And that's interesting.
When you do the fusion and you do the transrectal biopsies, the actual tracking devices, why they came was to exactly to see from where the biopsy has actually been taken. Because what happens is when you take the biopsy, the prostate also rotates a little bit in a transrectal biopsy, and the actual needle core that comes out is not the exact what you intended it to be. So the tracking devices that were there, the iGen devices and Uro-Nav, so they were able to track it better, and you will get a report. But in a freehand biopsy, you are not able to do that exactly from where they actually, and it is only in how well cognitive fusion
all
has been done.
biopsies are marked. You either take it, so you would say anterior, medial, anterior, lateral. So when you have 12 areas in the prostate that you've already marked and given it. So within reasonable limits, I think this is a good enough way to tell people where you've taken the biopsies.
So you are doing your all biopsies through this route, or you are selecting your patients in which
All
you will give
patients transperineal.
Okay. So any specific patient that you may want to do a PSMA directed biopsy?
Yeah, the post-APR, as I said, the first genesis of the thought was the patient.
Maybe the second biopsy status patients would benefit more with this.
Yeah, so there were patients where MRI was done and the biopsy was done, it was negative based on whatever cognitive fusions we could do. And then we did PSMA PET guided biopsy, and that turned out positive, and vice versa also. There are situations where PSMA targeted biopsy the trend was negative and we did MRI, that came as positive. So I think as the learning curve evolves, so probably combining both together somewhere down the line may give us the most accurate lesion. But one good thing out of this targeted biopsy, I can say that you're not hitting the entire prostate, so we're only targeting the lesion. And if you have a specific SV cutoffs which are more better defined in future, so doing an early prostatectomy and things like that might also become true. That you don't have to wait for 6 weeks for the inflammation, hematoma, everything settled, because you targeted only a very small lesion and you are not transgress the rectal planes, which we do normally in a normal transrectal biopsies or even a perineal biopsy. You'll have a lot of periprostatic hematoma around it.
Dr. Manohar, the tracking device is available in the stabilized version, I believe. Yeah. So do you do it, the tracker device, so do you use it when you do that sort of biopsies, or
Yeah, it's
you don't rely on it?
regularly we do that same tracker, because the stabilizer is mainly the tracker. When you rotate it, the tracker goes to that area of lesion. So you can track it and exactly from where to where.
So what is the smallest voxel size that you are able to
2
exactly
millimeter.
accurately target?
2 millimeter. Apex, at the previously transect ultrasound was missed, PSA was raised, 7 PSA. I did a transect ultrasound saturation biopsy, it was missed. 1 year later, this PSA become 10.6. We did, that time we had this demo machine from Denmark, it had come. We used this, radiologist able to say the apex. We took biopsy from there, 2 millimeter lesion. It was 2 millimeter, he said that. Basically, it is, Pirates 4 belongs to more than 1.5 centimeter. If it is 1.5 centimeters, you are accurate. It belongs to Pirates 4. But some radiologist to tell less than 1 centimeter, it is Pirates 3 or Pirates 4, he should be very good. Is basically. So he is able to get that. So we tracked it, took it. 2 pieces we took, it came positive. Even the same histopathology report came positive. So that is accuracy.
So can I have a question? I just wanted to know that what is is there Indian data regarding the incidence of sepsis during transrectal prostate biopsies? And the second question is that the facility of MRI fusion of transperineal biopsy is available in how many centers in India?
My experience of infection is, Indian data, it's a worldwide literature is 2 to 12%. Sometimes some of the papers mention 22% also. In fact, in the British, the paper has come as Brexit, where they've exited the transrectal ultrasound and is going into US and Europe also, the rest of the places. And if the infection happens, it's a severe sepsis. Previously, last patient, there was a huge prostate. We did one transrectal biopsy because in the other hospital we didn't have, and that patient went into sepsis. So infection is not the botheration. The infection, if it is treatable, it's okay. Once the patient falls into sepsis, it goes to the ICU, that is the bothersome thing. Even one patient goes to sepsis, you might have done 100 cases, but one patient of sepsis is real bothersome. That's what I could gauge. But I think everybody will agree under 2%. I also done 2000 transrectal ultrasound. I don't think it's less than 2% infection. But it happens in the tandem. In 1 month, particular month, 5 cases, everything is getting infected. So rest of it's in India, the same infection. You are doing in an OT theater, suddenly 1 month you have 4 cases of infections happening. This is the scenario in our scenario. So I think we should be careful about that. And transrectal ultrasound, MRI fusion, I don't know what are the places. The second answer, I think you agree with that. 2 to 12% infection is.
For transrectal, it goes up to 10%.
No, 2 to 12%, of course.
Thank you so much, Dr. Anand, Dr. Manohar, Dr. Ravi. Thank you, panelists. And may I call upon the stage Dr. Amit Ghosh, Dr. Shrenik Shah,